Dear students, welcome to BluepenOnline. Shall we begin? Please use headset, pen and paper to take notes.
Here you go. Please let's know your feedback after class.
Welcome to BluepenOnline.com. We continue with our journey to Hematology Part 3. In today's session, we shall discuss hemophilia, DIC, acute leukemias. My name is Dr. Shweta. Before we go further, let us discuss the basics of, let us brush up our basics in coagulation cascade. The basics. It involves the intrinsic pathway, the extrinsic pathway. The intrinsic pathway first begins with factor 12A activation, then factor 11, 9, and finally factor 10. On the other hand, the extrinsic pathway begins with the activation of factor 7. The intrinsic pathway is evaluated by a test known as APTT, while the extrinsic pathway is judged by a test known as PTINR. So by these tests, we can judge whether our coagulation cascade is intact or impaired. One of these diseases is known as hemophilia. Now, what is hemophilia? Hemophilia is a rare inherited bleeding disorder due to inherited deficiencies in clotting factors. It is an excellent recessive disorder, hence predominantly affects males. It is found in all populations and all regions of the world. It is a lifelong disorder. How do we classify hemophilia? Hemophilia is of the common types: hemophilia A, which is also known as the classic disease, which is extremely severe, and it is due to factor 8 deficiency. Hemophilia B is known as the Christmas disease, which involves factor 9 deficiency. But this is not as severe as hemophilia A. It is moderate. The third type is von Willebrand's disease, which is a bleeding disorder with low levels of factor 8, but also an abnormality of platelet adhesiveness. Today we shall concentrate on hemophilia A and B, of which hemophilia A is more common. What happens in hemophilia A? Whenever there is injury to the blood vessel, bleeding starts. In response to this bleeding, the vessel constricts and clotting factors are activated. Normally, along with the other substances, clotting factor 8 causes a strong platelet plug to form. Once a platelet plug is formed, a fibrin clot forms over this platelet plug and it seals the injury and bleeding stops. In patients who have hemophilia A, they lack clotting factor 8. So a weak platelet plug is formed. So incomplete or delayed fibrin clot allows bleeding to continue. So there is continuous bleeding. Clinical manifestations of hemophilia are usually noticed when the children after the age of 6 months begin moving around and losing teeth. These children have spontaneous bleeding, hemarthrosis, that is bleeding into joints, deep tissue hemorrhage, nosebleeds, easy bruising, hematuria, and life-threatening bleeding like CNS bleeding, neck and throat bleeding, the abdominal bleeding, and iliopsoas bleeding, causing restriction of movement at the hip. So how do I investigate a patient whom I suspect to have hemophilia? I do the following tests. Kindly recall, APTT is a test used for my intrinsic pathway. So if I have factor 8 deficiency, my APTT is prolonged because factor 8 is a part of intrinsic pathway. But my PT-INR is normal, my platelet is normal, and factor 8 and 9 levels are decreased. So once I confirm that there is deficiency of either factor 8 or factor 9, the mainstay of treatment is replacement of these clotting factors. They are available as recombinant factors at various centers. These clotting factors should be encouraged as prophylaxis rather than on demand. In case clotting factors are not available, in emergency you can use FFP or cryoprecipitate. DDAVP is a drug that transiently increases factor 8, but it is not curative. Antifibrinolytic agents like epsilon aminocaproic acid, tranexamic acid can be used to stop bleeding. Our next disease for the day is disseminated intravascular coagulation. What is the definition? DIC is an acquired thrombotic and hemorrhagic syndrome characterized by abnormal activation of the clotting cascade and accelerated fibrinolysis. This results in widespread clotting in small vessels with consumption of clotting factors and platelets so that bleeding and thrombosis occur spontaneously. A very difficult disease to manage because the patient will have bleeding on one end and thrombosis simultaneously. How does it occur? The pathogenesis of DIC involves endothelial damage. Endothelial damage causes clotting factor activation. So there is microvascular thrombi. Widespread consumption of clotting factors leads to platelet consumption, coagulation factor consumption, and activation of fibrinolysis. So on one hand, you have extensive thrombosis, on the other hand, you have bleeding tendencies, which lead to impaired coagulation and bleeding, and widespread thrombosis can lead to multi-organ ischemia or failure. So what causes DIC? DIC, the obstetric causes include amniotic fluid embolism, abruptio placenta, placenta previa and accreta, postpartum bleeding, HELLP syndrome, pre-eclampsia, septic abortion and intrauterine infection, acute fatty liver of pregnancy. The non-obstetric causes of DIC include sepsis, trauma, organ damage, leukemia, vascular aneurysm, acute liver failure, toxic and immunological causes, narcotic drugs, ABO incompatibility, transplant rejection. These are our non-obstetric causes. Out of these, the most important to remember are sepsis, acute liver failure, and toxic and immunological causes. So what are the clinical features? They depend on whether the disease is acute or chronic. Acute DIC develops rapidly over a period of hours, usually seen in your obstetric causes, and sepsis, where the patient will present with sudden bleeding from multiple sites that are normally like venipuncture sites, gum bleeding, hematemesis, and hematuria. It is treated as medical emergency. Chronic DIC, on the other hand, it develops over a period of months, may be subclinical, and eventually evolves into an acute DIC pattern. The investigations in a case of DIC include evaluation of my CBC, which will show decreased platelets, prolonged PT, prolonged APTT, because all my clotting factors are consumed. Increased fibrin split products. The treatment of DIC is because there is systemic activation of coagulation. I have to manage both clotting as well as bleeding. It is one of the most difficult treatment conditions. So how do I, manage such a difficult condition? The cornerstone of management is the treatment of underlying disease. Supportive management is based on the predominant symptom. So if the predominant symptom is clotting, then we use low-dose heparin treatment, administration of antithrombin 3, activated protein C, so that the clot lysis occurs or it prevents clot formation. If bleeding is the predominant symptom, then I can use platelet transfusion and give fresh frozen plasma or cryoprecipitate. But the cornerstone of the management is treatment of underlying disease. So how do I treat the underlying disease? Treatment of sepsis with antibiotics, incomplete abortion management, pre-eclampsia and eclampsia, treatment of underlying malignancies. This concludes our treatment of DIC. We move on next to an important topic of leukemias. What exactly is a leukemia? Leukemia is a malignant disease of the hematopoietic tissue characterized by the replacement of normal bone marrow elements with abnormal blood cells. Leukemic cells are frequently present in the peripheral blood, commonly invade spleen, liver and lymph nodes and other tissues of the body. Example, testes, brain, meninges and skin. As we all know, WBCs are of two types, myelocytes and lymphocytes. The myelocytes are further divided into neutrophils, eosinophils, basophils and monocytes. Lymphocytes are of two types, B and T. We need to know this because the leukemias are classified as acute and chronic, but they are further classified as ALL, that is acute lymphoblastic leukemia, acute myeloid leukemia, and the chronic is similarly divided into CML, that is chronic myeloid leukemia, and chronic lymphocytic leukemia. So what is acute leukemia? Acute leukemia is the presence of more than 30% of the blasts in the bone marrow. So what is a blast? A blast is nothing but a stem cell which is not mature, but it has high proliferation capacity. It is not mature and has high proliferation capacity. These blast cells do not enter the peripheral blood normally. If one blast cell becomes mutant, if it undergoes mutation, then it gives rise to leukemia. If the myeloid blast becomes mutant, it gives rise to AML. If the lymphoid blast or the lymphoblast becomes mutant, it gives rise to ALL. So based on which blast is involved, it is divided into acute lymphoblastic leukemia and acute myeloid leukemia. So acute lymphoblastic leukemia, we will deal it under the following topics: definition, classification, clinical features, your laboratory investigations, and your diagnosis and management. So definition of acute lymphoblastic leukemia. ALL is malignant disease of the bone marrow in which early lymphoid precursors, that is your blast cells, they proliferate and replace the normal hematopoietic cells. It is the most common leukemia in children. So how can we classify ALL? There are two classifications for ALL. One is the French American British classification, which is based on morphology, and the other is WHO classification. Let us have a look on the FAB classification. Just based on the morphology, it is divided into L1, L2 and L3. As you can see, L1 is small cells with scant cytoplasm with indistinct nucleoli, that is, the nucleoli are not visible. L2 are large heterogeneous cells with moderately abundant cytoplasm and sometimes clefting and indentation of the nucleus, large prominent nucleoli. L3, these are large cells with moderately abundant cytoplasm, regular oval to round nucleus, prominent nucleoli, prominent cytoplasmic basophilia and cytoplasmic vacuoles. The drawback of FAB classification is it concentrated only on the morphology and did not tell us about the genetic abnormality and did not help us in treatment. Hence, the WHO has classified ALL into pre-B ALL, T-cell ALL and mature B-cell ALL. 75% of the cases, majority is pre-B ALL. You can see the WHO has incorporated the FAB into its classification. And it also tells us about the cytogenetic abnormalities. So how does the patient with ALL present to you? The child will present with pallor, lethargy, malaise, dyspnea due to anemia, fever, malaise, features of mouth, skin, respiratory infections due to neutropenia. So you have decreased HB, decreased WBC, and spontaneous bruising, purpura, bleeding gums due to thrombocytopenia, decreased platelet. Generalized lymphadenopathy, hepatomegaly, splenomegaly, and organ infiltration. So what are the organs? Bony infiltration, testicular infiltration, CNS infiltration, and lastly, fever. So the investigations in a case of ALL includes CBC, where there is low HB, low WBC, and low platelet. This is because abnormal proliferation of lymphoblasts in the bone marrow suppress all other cell lines. They occupy so much space that other cell lines are suppressed. Peripheral smear, normocytic normochromic anemia with lymphoblasts, large cells with big rounded nuclei, prominent nucleoli. Occasionally, you can see cleft cells. Now, what are cleft cells? Those are cells which have clefts in their nuclei. Can you see here? A cleft within the nucleus. On examination of the bone marrow, abnormally large, more than 30% of bone marrow is filled with lymphoblasts. To confirm a diagnosis, we can do a flow cytometry that will show us markers for lymphoblasts, and cytogenetics is evaluation of the genes which confirm ALL. To treat ALL, the following chemotherapeutic agents are used: glucocorticoids, particularly prednisolone, vincristine, L-asparginase, methotrexate, and anthracyclines. These chemotherapeutic agents are used in combination. Methotrexate is also given intrathecally, that is directly into the cerebrospinal fluid, to treat CNS leukemia, that is infiltration of ALL into the brain. With this, we come to an end of ALL. We shall continue our journey into hematology in our next class. Thank you.